Perfect. Thank you, Gloria. All right, welcome everybody to our ASAM Monthly Technical Assistance Series for the month of July. I hope everybody had a nice holiday last week. Happy to see such a large group here today. Again, my name is Kathleen Hoagland. I am the Program Representative Supervisor in the Division of Program Support and Quality Improvement at DDAP. I'm really happy that you can join us today. So we're going to go ahead and just do a couple of reminders. So we always encourage folks to submit questions on the topic. So obviously the topic for this month is documentation preparation for the ASAM alignment reviews. And we try to send out a reminder or just kind of a notice of what the topic is going to be about 2 weeks or 10 days in advance of this meeting so that people can submit questions. And we didn't really get any questions this go around. So I'm going to try to save some time at the end to field some questions live today. But please note that you are on mute right now, and there's going to be opportunities today to participate. And so if you do want to participate or answer a question or give some feedback, how you can do that is you can either type in the chat or you can raise your hand. And then I or Gloria will unmute you so that you can participate. We're not trying to be rude. We're just trying to make sure that there's not a lot of noise kind of coming in on the call. So everybody is muted right now, just so you know that. Again, this call is being recorded, so please exit now if you don't want to be recorded. You can view this content at a later date on the ASAM transition website. And if you have any suggestions for future call topics, you can always submit those to us at the ASAM resource account, and I have that noted in front of us right here. Just a little disclaimer, and we kind of do this in the beginning of every ASAM monthly TA call. So alignment with the ASAM criteria is required for drug and alcohol treatment providers that receive funding for providing treatment services under agreements with single county authorities and or managed care organizations. Really stress the importance of everybody reviewing the ASAM text in its entirety and attending the various trainings that we have available, and also referencing a lot of the documents and resources that we've created for the field. Really going to be talking about those three things today a lot as resources for you as you begin to prep documents for the ASAM alignment reviews. So we're going to really be digging into that a little bit more today. Our learning objectives for the call today are going to be to understand the kind of documents that we're going to be asking providers to submit as part of the ASAM alignment review. Just want to really stress that today we're focusing on ASAM level 3.5 because that is the level of care that alignment reviews will start with, is ASAM level 3.5. So we are going to be focusing on that level of care today. Please know, though, that a lot of what we're talking about today is going to be applicable to all levels of care, specifically some of those fundamental ASAM concepts, which we'll be covering. We're going to be identifying tools and resources available to assist providers in preparing for the ASAM alignment review and the document portion of that. We're going to be really helping folks understand some key elements of the ASAM criteria that really need to be incorporated in all documents and obviously into practice. And then finally, we're going to be reviewing a few examples of ASAM aligned documentation versus non-ASAM aligned documentation. So I want to stress the word examples here. So we're going to be showing two specific examples today. And the purpose of sharing these examples is really to be of assistance to you all. This is not us saying this is what it exactly needs to look like. It's really just to give you an idea of what we may be looking for in these alignment reviews. Our hope is that this can be a resource for you today. All right, and I see quite a few more folks have joined us. I think we're in a good spot to start digging in. I just want to make sure, since we are going to be covering some important topics today, that we have as many people in as possible. Okay, I think we're looking good. All right, so kind of the first thing that we're going to be covering today is the kind of documentation that programs are likely to be submitting as part of the ASAM alignment reviews. So you'll see here kind of a list. Obviously, those would be things like policies and procedures. We're going to be looking at program schedules, and we're going to be looking at things like training plans or job descriptions. They might be letters of agreement or QSOAs. So programs are going to be asked to submit a list of items that are needed to verify that the program is aligning with the ASAM criteria. And I want to stress that, for a lot of the tenets that we're going to talk about today, formal policies and procedures may not be required for all areas. However, the program must have a way to illustrate that to show that they have evidence to support alignment. So again, these are kind of some of the major things that we would be asking folks to submit. This is not an all-inclusive list. There's probably some things here that I'm missing. And so just want to give you kind of a general idea of some of the things that we're going to be looking for. Okay, so we have some really, really helpful tools to help people prep for this specific portion of the ASAM alignment review. So that's the documentation kind of portion of it. In the next few slides, I'm going to be showing you how to use the second thing that I have noted here. So the level of care specific self-assessment checklist, and I actually put that in the chat this morning. I put the level 3.5 checklist in the chat this morning. It's way at the top of the chat. So this is something that we're going to be talking about today in depth. And if you can, I would pull that up as we're talking about it so that you can really look at how we can apply this and use this to help your programs prepare for the documentation portion of the ASAM alignment review. So we're going to be talking about that in depth today and how to use that checklist. And then also a lot of the concepts that I'm talking about today. So, individualized services, interdisciplinary teams, co-occurring capability, a lot of those central tenets of ASAM are actually topics that we've covered in previous ASAM alignment calls. And so I actually put a screenshot of the different topics that we've covered since November to last month. And so these are all really important central tenets of ASAM that folks really need to understand and know how to apply, and their teams need to know how to do this. So these are already available to you all on our website. So it includes the recording and it includes the slides. And then in the call, if there was questions and answers that went unanswered during that call, then those are actually listed here as well. So just want to remind folks that this is available on the ASAM transition website. And I was really happy. I think it was last week, I actually heard a program saying that they had used these calls as a training resource, and they actually every week when they do kind of a clinical supervision meeting, they also kind of tag on one of these calls and they watch it as a team in preparation for ASAM alignment reviews, but also just as a training opportunity. And I was really excited to hear that because that's really what we want these to be used for. And so I'm just wondering, I'm going to take a second here, if anybody can type in the chat. Are folks, accessing these specific calls that I have noted here, the recordings and the slides, are they using those? Are they accessing those as a team? Are they using them as a resource to help teams understand ASAM better and to prep? You can just kind of put yes or no in the chat box. You're not going to hurt my feelings if you don't put anything. I just want to know if other people are doing this because I found it really exciting to hear that there was a program that is using these. So I see Kim said yes, awesome. Fern, great. Avery, fantastic. Really would encourage folks, yeah, perfect, to use these as a resource. And glad to hear that some people are using it the way that we kind of hope people would use it. So fantastic. And for those of you who haven't accessed those are available, free, public use. Please take a moment to check those out. Fantastic. Okay. All right, let me go on here. Just letting a couple more folks in the call. Welcome to those of you who are kind of just joining us. If you've missed the first couple of slides, you can always access those at a later date on our ASAM transition website. Okay, so in front of us right here, what I did is, and again, I actually put the link for this specific resource in the chat. It's way in the beginning of the chat. I put it in there at the beginning of the presentation today. So there's a self-assessment checklist for every single level of care on the ASAM transition website. These are such critical resources for people to be using. So I put a screenshot here of how you get there. So you would go to the ASAM transition webpage, you would click on the level. So for this one, it would be level 3.0, residential inpatient services. And then you would click to the level 3.5 self-assessment checklist. These are PDF documents. They can be printed. They are for public use. So we're going to go on to the next slide here, and we're going to look at an example of how this will show up for you all. And I'm actually, so this is the 3.5 checklist. If you have it in front of you, great, you can follow along. We're going to be talking about this checklist quite a bit today during the call. So this is a section of the 3.5 checklist, and I actually have the section about random drug screening because that's one of the examples that we're going to be doing today. We're going to be doing kind of an example policy for urine drug screening today. So it kind of shows you how these are laid out or how the checklists are laid out. It has a citation to the ASAM text, which I really appreciate because it kind of helps me understand, okay, this is in the ASAM text. This is not something that is kind of irrelevant or that's made up. This is in the ASAM text. It's noted here. And then it kind of lists out what really should be in a policy or documentation to illustrate that the program is actually employing ASAM with regards to random urine drug screening for the specific level of care. So this is how they're laid out. And so this is, I believe this specific document's maybe 8 or 9 pages, but it's a really helpful way for programs to start understanding, how do we make sure that our policies are put together appropriately so that we're ready for these ASAM alignment reviews. So if you haven't accessed those checklists, please do so, and you can pull it up today even while we're talking about them because we're going to go into them in more detail in a minute here. All right, so before we dig in any further, I have a little stop sign here because I just want to make sure that there's a couple of different things that people are thinking about today as we're having this call and as you're all preparing your documents for ASAM alignment reviews for ASAM level 3.5. So there's a couple really, really critical questions that I really encourage programs to be asking themselves. So I listed them out here, but I just think making sure that the policy isn't just there to kind of pass an alignment review, but at the point that there's a chart review or an interview with staff, it's clear that the policy and the practice really match up. So are you actually doing what the policy says that you are doing? That's the purpose of the policy essentially is that, to make sure that this is actually happening in clinical practice, that staff have a very clear expectation about what should be happening in clinical practice and program wide. So the other thing here is that many of you are kind of already providing services that are already aligned with ASAM. You're providing, individualized patient-centered care. You may offer a variety of evidence-based practices, and you might be extremely mindful of the patient's goals and their needs. They are front and center in treatment. But there may be a situation where you're doing all those things, but it's not clear in looking at your policies and procedures, right? So are you giving your program justice? Are you specific in your policy, and are you illustrating what your staff have actually been working so hard in doing? Making sure that those things really match up, because we don't want that to happen. We want people to get credit. We want programs to get credit for the hard work that they've been putting in with ASAM alignment. And the policy has got to really show us or speak to us and spell out what exactly you're all doing. You want to obviously make sure your policies are not dated. So if we're seeing a policy kind of, last edited in 2008, obviously that's like way pre-ASAM, and chances are that it's not going to be in line with ASAM. So, making sure that you're updating, when you last kind of, made sure these policies and procedures were up to date. Making sure that the policies kind of really integrate the 6 dimensions. Do your policies reflect just one level of care or multiple levels of care? So for example, 3.5 has different admission requirements than 3.7. So just being mindful of that, and is that reflected in your policies? Is that really only able to be viewed in your charts? So making sure that's spelled out in the policy. And we absolutely acknowledge that some policies and procedures must be in place due to licensing requirements. And that's obviously extremely critical. However, we're looking for alignment reviews. We're looking at policies at a clinical and a quality lens and how they're incorporating ASAM into everyday practice. And so we want to make sure that we're going above and beyond, the licensing requirements. And we're really looking at that clinical and that quality piece that ASAM really kind of makes us bring along with our daily practice. And I do want to note here that licensing did want me to mention that if you're changing policies to kind of just enhance them or to be more ASAM aligned, to not sign attestations. And so if you have any questions about that, I do believe there are some folks from licensing that are in the meeting today, and you can kind of type any questions in the chat about that as we're going along. So these are some of the things that you really want to be mindful of when you're prepping policies. Okay, so I wish there's a lot of key concepts, obviously, with ASAM. I couldn't list them all here. But when I was preparing this, I was really asking myself, what are the really key, critical, fundamental concepts to incorporate across all levels of care in practice, but then, making sure that these are really kind of present in the policy and the documentation submission portion of the ASAM alignment reviews. So obviously I have here, individualized and patient-centered care, interdisciplinary team. I have quite a few other definitions. I did, just to help folks, and I really do want to make this be a resource for people. So I did put, key pages where these areas are discussed. And if I don't have a page noted, like for instance, under the 6 dimensions, it's obviously not because the ASAM doesn't talk about that. It's because it's talked about kind of so much throughout the text that it's really, it's in so many different areas. And so I just kind of left it blank there. So these are really some of the key tenets to incorporate across all levels of care in your policies and procedures, in your practice. And so I thought it would be kind of interesting. So I put what I thought was really critical and important to filter into these practices and policies. But is there anything that I am missing here on my list that you all think really needs to be kind of in this list of the key ASAM concepts? If you can just kind of type in the chat, what you think would need to be added. I would be really interested to kind of see what other folks think I maybe missed here. So I'm just going to give everybody a minute if there's anything they want to add in the chat. So Missy saying she's not able to locate the list that I'm referring to. So I'm actually just talking about the list that I have up here, Missy. So I was just asking about if there's anything that you think is kind of missing. Like what I'm asking basically, what are those really key fundamental concepts of ASAM that we want to be mindful of as we're looking at our policies and procedures and practices? So it's really just kind of asking you for your opinion on that. Meeting the client where they're at. Thank you, Avery. Okay. Some of the other ones, yeah, so Missy, everything that and this is just for folks who are maybe just joining us today for the first time. So everything that I'm covering today, what you're seeing is available for everybody after the call on the ASAM transition website. It's going to be both the recording and the slides are available. So just so everybody knows that. Some of the other ones that I thought, I kind of questioned about including, and they're obviously really critical, trauma-informed care, spirituality, there's a lot of different things that we can add to these core concepts, but I thought this was a good starting point. All right, so I am going to go on to the next slide here. Okay, so here's what we're going to be doing now. So we're going to be going into some examples of some policies and procedures. And I picked 2 different kind of topics. So I picked daily clinical services / therapies, and I picked urine drug testing. So I'm going to explain to you kind of how we're going to do this. And then I am going to be asking for some participation as we're going through these examples. These are examples. I just want to give that another shout out. These are examples. This is not exactly what you have to be doing. Just giving you a general idea of maybe what you can be working towards. So this is not DDAP saying this is exactly what you need to have. Please understand that these are just examples. Really, I want to make this a resource for everybody and make sure this is as helpful as possible. All right, so again, we're looking at ASAM level 3.5, okay? If you have your self-assessment checklist available, I would pull that up for you. I would pull that up as we're talking about this if you can. So we're talking about ASAM level 3.5. The topic we're looking at is daily clinical services / therapies, okay? What I did was I looked at that 3.5 self-assessment checklist. I looked at what was noted in that checklist under this topic. So you can see a list of bullets here. It says evidence of a lot of different things, a daily schedule of activities designed to improve patients' ability to structure and organize daily living tasks, evidence of a full range of therapies and educational activities matched to the population served, right? Evidence of community reinforcement activities like community meetings, evidence that shows individual and group programs to cover a full range of professional services matched to the population served. Talks about individual and group therapy. It talks about family therapy, evidence that there are interventions focused on applying recovery skills. Okay, so these are actually all, if you're wondering where this is coming from, this is coming from that ASAM level 3.5 self-assessment checklist. Okay, so hopefully that's clear to everybody. And so hopefully you can kind of follow along. It's exactly on pages actually 4, 5, and 6 of that checklist. So I'm using that as I'm developing this example policy. Okay. So what I'm going to do is I'm going to show you an example policy that is pre-ASAM alignment first. Okay, so I'm not going to read this verbatim. I'm going to let you all kind of read this in your own time. I'm going to give everybody 1 to 2 minutes to take a look at this. As you're looking at this, I am going to ask you to type in the chat or to raise your hand to speak about the areas on this example that may not be ASAM aligned in nature. So I'm going to give you 1 to 2 minutes here. I'm going to mute myself, and then I'm going to come back on and see what you all have here. All right, I see some really good feedback here in the chat. Fantastic. Does anybody want to raise their hand and speak up and actually kind of just discuss a little bit of what they're seeing here and maybe what is not so ASAM aligned in this example policy? Okay. So what I'm going to do is I'm going to speak to some of the comments in the chat, and then I'm just going to give some general feedback about why this is pre-ASAM alignment, and it's really not, it's missing the mark essentially here. So a couple different things here. So there's only one model, obviously, and I see a lot of people put this, right? So everybody sees that there's just an abstinence-based model here. So there's only one model, right, being employed. And what happens, or I guess my question is, what happens to those patients in the program who do not want an abstinence-based model, or they're requesting a different model? What would that be like for them to be in this program, that is entirely focused on this one model? Is it respectful and patient-driven? Is that patient-centered? The answer to that is no, right? So we want there to be a lot of patient participation. We want patients to be front and center when really discussing the kind of model of programs that they want to be in and that they think work for themselves. So when you just have one model, it really kind of pigeonholes people into that one model, essentially, and there's no room for individualization of treatment, which is a problem. So a lot of you kind of noted that. So great job. This policy does not list out a comprehensive list of therapies that should be included at ASAM level 3.5. And this is such a big one. And I want to really reiterate this. If you have your ASAM text in front of you right now, I would, open up pages 251 and 252. So for ASAM level 3.5, there is a listing of therapies under that therapy section. This is essentially the list of all the different kinds of therapies and interventions that really need to be included on a daily basis, or they need to be available at least, right? So they would need to be available because if we're individualizing treatment, then we need to be able to tailor that treatment to the individual needs. And when you only have one or two different things available or two different interventions available, it's hard to individualize treatment. So again, pages 251 and 252 of the ASAM text list therapies. So a lot of those therapies are missing from this, right? So I don't see any mention of family involvement. I don't see any mention of medication management. There's no mention of the use of motivational interviewing or motivational enhancements. There's no mention of interventions geared at helping folks reintegrate back into society or school or work or family, and like recreational and art therapies and occupational therapies are not mentioned. Health education isn't mentioned. So those are all those things that I mentioned on page 251 and 252, right? Those are missing here. So, and the thing that may be happening with this policy is that there's a chance that the program has changed and that they have become aligned with ASAM, but maybe that policy doesn't match up with that, right? And so maybe we come in and we look at the chart and they are actually providing all these things. Well, we're not seeing it in the policy. So making sure that those things all kind of tie back with each other. So the third thing here is that, so there's a difference obviously between 12-step facilitation, which is an evidence-based practice, and then 12-step meetings, right? So 12-step facilitation is, again, an evidence-based practice. It is considered a clinical intervention versus 12-step meetings. 12-step meetings are not counted as daily clinical services. So they and other kind of mutual and self-help meetings are absolutely critical. We all know this, but they should not be listed under clinical activities or a daily therapies policy. And then finally, this is a really vague policy, right? So frequencies, like how often somebody's getting an intervention, how this intervention is tailored to the individual and tied back to their treatment plan and their goals and their needs is not spelled out here. So we have no idea how that's working. And if we don't spell it out here, then how do we know, or how do we expect our staff to know how to operate on a daily basis? How are the expectations very clear to them, and to patients? So those are some of the kind of general kind of comments about this pre-ASAM aligned policy. And I just want to make sure, Jennifer Reeder, not individualized, no evidence of family, pharmacotherapy, no MI. Yep. Not everyone's going to be interested in 12-step meetings. Absolutely. Very good comments on here. So you nailed it. Fantastic. We're going to go on to the next one. So we're going to go on to the ASAM aligned example. Okay. Again, this is not DDAP saying this is what your policy needs to look like. This is just an example, folks. We're just trying to help out here. Okay. So this is the ASAM aligned example. So this is actually 2 pages. Okay, so I'm gonna show you the first page, and then we're gonna go on to the second page. So we'll start with this one. Take a minute to take a look at this, and then you feel free to type in the chat. What are you seeing with this one that is more ASAM aligned in nature? So just give yourselves a minute. I'm gonna put myself on mute. Feel free to type in the chat. I'm going to go on to the second page now. See some good comments already. You can continue as you're reading this. If you want to type in the chat, please do so. All right. I realize there's a lot on this slide, and this is an example policy. So putting it on a slide is very full. And so if you didn't have an opportunity to read this in its entirety, just want to make sure people know that this will be available on the ASAM website after the fact or after the call today. So I saw some really great comments. So they could kind of see that this obviously is very individualized and evidence-based and person-centered. It's trauma-informed. So basically, kind of what's happening here is very, I know it's a lot, but it is pretty basic. So all the therapies that I've mentioned on page 251 and 252 are included in this list, right? It's clear that the patients are a part, or they are front and center of their treatment every step of the way, right? Daily programming is tailored to the individual's unique history, their set of needs, their goals, their beliefs. It is specific. I mean, look at the medication management line, which I realize that, there's probably a standalone policy for medication management, but even if it was just this line, I mean, they talk about when the assessment's completed, how closely patients' medications are monitored, how frequently they're monitored, how frequently the patients see the provider and the nursing for regular checkups, and the fact that the frequency is really based on patient needs. So it's not like cookie cutter, right? So it's maybe once an admission, then as needed as treatment kind of goes on or as the patient is progressing. So it is very clear. It's spelled out. We can look at this and say, wow, like this is really comprehensive. There is a lot here available to the patient if it's appropriate to them and if they need that and if the clinical team recommends that. And we know how frequently it's happening, and it's very specific. So this is an example again. This is going to be available to you on the website after the call today. So I thought that might be helpful to kind of go through that. We're going to go on to the next slide here, looking at the time. And I just want to do a kind of a reminder. I think everybody is really clear on this at this point in ASAM alignment, but you may have noticed that AA meetings or other recovery meetings or peer support were not listed on the last slide, illustrating the example of daily clinical services. And I think we all kind of know why that is at this point, but I just want to point out that definition of skilled treatment services on page 429. And I'm not going to read it off the slide here. You all can kind of see it for yourselves, and you can also reference the ASAM text. But I really like this definition because it really clearly spells out like what is not involved in skilled treatment services. Things like homework assignments involving watching videos and journaling and workbooks. Like that's not skilled treatment services. And so it also kind of spells out like the role that AA and NA and other things like that play into this. Again, I'm not downplaying the extremely critical nature of AA and NA and Smart Recovery and Celebrate Recovery and the other self-help and mutual aid groups that are available. Those are very critical for people in recovery, but they should be not included in daily clinical services, and it really should be individualized to the person, and what they want and what they need really needs to be factored in throughout their treatment stay. Okay, so this is our second example, urine drug testing. And so so what I'm doing here, I'm gonna say it out loud again. So if you're just joining us, you know what we're talking about. So we are using the ASAM level 3.5 self-assessment checklist, which is available on the ASAM transition website. We are using that today. I'm pulling out pieces from that checklist on specific areas, and we're using this. I'm showing you how to use this checklist as a resource when preparing policies and procedures and other documentation for ASAM alignment review. So what you see in front of you is taken right out of that ASAM level 3.5 checklist. In fact, it's on page 5 of that checklist if you have it pulled up. And so, and just for those of you who, want to know the ASAM reference, so in ASAM level 3.5 on page 251 of the ASAM text, that section states, random drug screening to shape behavior and reinforce treatment gains as appropriate to the individual's treatment plan. Okay, so that's on page 251 if you want to know that reference. So again, what you're seeing in front of you is straight out of the ASAM 3.5 checklist. I pulled this out, and what we're going to do is we're going to go through a pre-ASAM aligned example of urine drug testing policies and procedures, and then we're going to look at maybe what an ASAM aligned looks like. So I'm going to go through here. Okay, so same drill here. So I'm gonna give you an opportunity. This is a 1-page example here. So I'm gonna give you an opportunity to take a look at this drug testing policy for a minute. Type in the chat what you're seeing. What do you see that is not ASAM aligned? Okay, I'm gonna mute myself and come back on in a minute here to give you a chance to look at this. Okay. Thanks everybody who put feedback in the chat. See a lot of comments about kind of the immediate discharge for a positive urine drug test, not individualized. Jennifer, great point. So I'm just going to kind of go through a list here. Does not identify when and why another drug screen would be required. Yep. And also leaves no means for a client to continue with treatment should they have a positive UDS. Okay, perfect. Great feedback in the chat. Thank you, everybody, for participating. If you have anything else, you can continue to type in there, but I'm just going to kind of go through point by point kind of what this policy is missing here. So number one, lack of individualization. I already saw somebody put that in the chat. There's no evidence in this policy that there is any kind of individualization happening with regards to urine drug testing for a patient. There's no randomization of urine drug testing. There is no no evidence that the patient was involved in the drug testing process. Urine drug testing is not being used to reinforce treatment gains. Okay. It's unclear how testing is being tied back to the individual's treatment plan. And it appears here that a positive urine drug screen would result in a discharge, not maybe kind of an amendment to the treatment plan. So there's a lot of different things here that are kind of missing. So I'm going to go on to the ASAM aligned example. Okay, so this is a long. I'm just gonna warn people. And I don't mean to scare everybody, but this is a long policy. So this one is about 3 or 4 pages. Again, this will be available on the ASAM website. This is a very long policy. So hopefully you'll kind of see why, and this will make sense to you in a minute. So I'm going to go through this page by page. I want you to ask yourself, what are you seeing in this policy that is ASAM aligned in nature? What is working here? Okay, I'm going to go through page 1 first, and then I'm going to go through all the other ones. And we're going to take really the last probably 7 minutes of this. And I just want to ask for feedback if you can type that in the chat as we're going along here. So I'm going to stop talking, and then I'm going to start paging through here. I'll give everybody a couple minutes to go through this first one, and then we'll do that for the other pages. Okay, I'm going to go on to the second page. So your job here, what I'm asking folks to do is to identify what they see here that is ASAM aligned. Okay, so ask yourself, what am I seeing here that is ASAM aligned? What am I seeing here that's working for ASAM alignment? Type in the chat what you see. Okay, and then this is the last page, I promise, of this policy. And again, just asking for some feedback about what people are seeing in this policy that is ASAM aligned in nature. Okay, I'm going to give everybody 1 more minute. And if there's any other comments or feedback about this specific policy, or if anybody wants me to go back to any of the pages of the policy, I can also do that. You can just type that in the chat. But I see some really good comments in here about this policy. And I think what I'm going to ask is, because I see so many really good comments, is there anybody who is willing to kind of unmute themselves, and I can unmute you if you raise your hand, that wants to speak about kind of what they saw in this example policy that was ASAM aligned in nature? Paul, I think I just unmuted you if you want to go ahead and share.
Sure. Yes. So the ASAM aligned policy, they are, because they are taking the UDS and then sitting down with the client and with the treatment team, looking at what does this drug screen say about the efficacy of our current treatment, and therefore what do we need to do differently in our treatment. I think that's very much the intent of ASAM compared to the other one, which simply said, too bad, too sad, you're out of here.
Paul, thank you so much for sharing and for your comments. You hit the nail on the head. I really appreciate your feedback. Anybody else want to speak up on this one? Okay, so thank you, Paul, again. And I want to go back to some of the comments in the chat here. So these comments take care of everything that I was essentially going to say. So with this urine drug testing policy, right? This is an example policy. There's a couple of things here that are extremely, extremely clear. So number one, the patient is they are involved in this. They are involved in at the very beginning of treatment, right? They understand the role that urine drug testing will play in their treatment. They have a say in the role that it plays in their treatment, okay? It is made clear, so there's patient consent. They are very clear in understanding that, listen, I know that this program uses the drug testing as a means to make sure that the treatment plan, just like Paul was saying, the treatment plan and the approach that we're taking is actually working. It's one way to measure effectiveness of treatment and my response to treatment, and I will understand that as a patient in the beginning, right? So the patient clearly understand that is explained to the patient, and that is just respectful of the patients, and it's respectful of staff and everybody else involved as well, right? So those things were present. There's written into this policy, it's very clear that if there is a positive, then that employs, it's an immediate response from the treatment team, right? There's no waiting about it. There is a conversation with the treatment team and with the patient. All right, what do we need to do differently? There's a positive here. What are we not doing? What are we missing here? What do we need to change? How do we need to adjust the treatment plan? Is this person in the right level of care? And asking the patient, what do they need? And then obviously this policy goes into different things like, making sure that the appropriate people are ordering the drug tests. It's very clear here which people in the staff are allowed to order urine drug tests and how that process takes place, right? And finally, on the last page here, it talks about what happens if there's a positive. Like I said, it's an immediate response. There's an immediacy to this, right? It's taken pretty seriously, but it's also not, I think this only works if the patient understands right in the beginning the role that urine drug testing plays in their treatment, right in the beginning. It's not a surprise to them. This is also a really trauma-informed concept for folks, right? They understand what is going to be happening to them, how it's going to be happening, how it's going to be used to help them and to not punish them, essentially. And so it's extremely specific, and that's why it's so long. I mean, it's 3 pages because it really lays out point by point how this works from start to finish. And it talks about the patient involvement in that and the role the clinical team plays, and the general philosophy the treatment program has regarding urine drug testing. All right. So, and I'm seeing a lot of questions about if this is going to be available on the DDAP website. Yeah. So for those of you who are maybe new to these meetings, these are all the point of having these meetings with you all on a monthly basis is to help folks in their understanding of ASAM alignment and to help folks kind of put this into real life practice. And we're getting to the point where we're getting ready for ASAM alignment reviews, level 3.5 coming first. And so we're really going to start to change these sessions to be more tailored to helping folks prepare for that. So yes, these are going to be available on the DDAP website. These examples, again, these are just examples. DDAP is not saying these are exactly what your policies need to look like. These are examples for you to use as a guide as you're preparing here for this process. And I just, again, want to say thank you so much to everybody who put comments in the chat on that last example. Just a lot of really good comments in here. It really helps me understand, like, there's a lot of people on here who absolutely grasp it and they understand kind of what this looks like in an ASAM aligned system. So thank you everybody for your participation. So, and then Lynn, drug screenings to inform treatment. Absolutely. It is a tool. It is one of many tools in treatment to inform it. All right, folks, so that is it. That is it for, nope, there's one last thing here on this example. The one last thing that I want to bring up here is that you can see here under the general procedure under 6D, before the drug test is administered, staff asking the patient if they have taken substances since entering treatment or if the drug test is going to be positive or negative. That's another example of kind of informed consent, right? And the patient participation in their treatment, giving them the opportunity to say, hey, yeah, you know what, this is going to be positive. On day 2 here, I forgot that I had this, this place and I decided to take this. So making sure that they're kind of involved and that they are a participant every step of the way. Again, this will be available on the DDAP ASAM transition website probably in the next couple of days or so, at least by the end of this week. We just have about 5 minutes left on this call today. And I just want to say thank you to everybody who's been participating, putting information in the chat. Paul, thanks for speaking up. I'm willing to take a couple of questions here if folks have those in the chat. I think I'm going to do it by chat mostly right now versus asking people to raise their hand just because we're a little bit limited on time. So now is your opportunity to ask questions in the chat if you have them, and we'll get to them as we can. Paul, thank you for that question. I cannot speak to that, but we will get back to you on that question after the call today. Thank you. Okay, Jody said, yes, we will be addressing this. Thank you, Jody. And if you don't have any questions about this topic, if others have examples of or requests for other topics in the next couple of months here, you can also type those in the chat. Okay, and then Kimberly had another question related to Paul's question. Okay, perfect. Thanks, Jody, for your help on those. All right, folks. Well, I don't see a lot of activity happening in the chat. And I did not put another slide for this, but we will have another, our next ASAM alignment call. They're always on the first Monday of every month, unless there's a holiday. So the next ASAM alignment call will be on Monday, August 1st. at 10 o'clock, and I will be sending out an announcement about what the topic is going to be in about 2 weeks here, and that will give you all an opportunity to submit questions ahead of time on that topic. And again, please be sure to access some of the resources that we talked about today on the ASAM Transition website. The material from this call today will be on the ASAM Transition website by the end of this week. And I just want to say thank you to everybody for being here today and for their participation. And please don't hesitate to reach out to us at the ASAM Transition email address. Maybe we can put that in the chat here if you have any additional questions. So thanks, everybody. I'll stay on until about 11 o'clock if there are some questions. All right, thanks, everybody. We're going to log off. Have a great rest of the day today.